The aim of this training is to increase reliability of stroke outcome data across the care pathway in Greater Manchester by standardising the training, as well as delivering an online training resource for outcome measures for all stroke clinicians. The expectations from the clinical teams is that you identify an outcome measure champion within each team who can support new starters. Teams could signpost training to all new starters and anyone who needs to refresh training. The teams are expected to allocate time for staff to complete training and maintain training sign-off sheet for each team. This training covers the importance of outcome measures data reliability. We cover 4 outcome measures that SNAP currently collect. These are Modified Rankin Score, Barthel Index, Nottingham Extended ADL Scale, and EQ5D-5L. Measuring patient outcomes is critical in evaluating the efficiency and effectiveness of care provided and can help demonstrate patient benefit following intervention by healthcare teams. We now measure the impacts of our hyperacute, acute, and post-acute care in Greater Manchester via the National Audit Programme and additional data collection via the network. The first outcome measure we look at is the Modified Rankin Scale. Please find the link to the copy of this on the website. The MRS is a popular outcome measure and has ordinal scale categories ranging from 0, where there are no symptoms, to 5, involving complete physical dependence. The scale ranges from 0 to 5, 0 being no symptoms to 5 being severe disability. Please read the descriptions on the slide. Previous and current issues include MRS data being entered onto SNAP by non-therapists via medical notes, i.e., not a clinician who has seen the patient. Secondly, MRS scores are recorded onto SNAP by stroke units differing from those recorded at first contact by community teams. Finally, there is variation in how MRS is being applied and recorded. There appears to be a lack of consistency, highlighting a training need for people using the tools. Guidance for use. Make sure you're in a quiet space with privacy. If a patient has communication or cognitive problems, use a proxy to support them. Make sure you base on post-stroke symptoms, not old ones. Walking aids or other necessary mechanical devices, apart from wheelchairs, are disregarded, provided that the patients can use them independently. For this purpose, usual is regarded as any activity that they use to undertake for a monthly basis or more frequently. If patients have any symptoms resulting from the stroke, whether physical or mental, then they should be scored at least 1 on the Rankin scale. For example, if they have any new difficulty in speech, reading or writing, in physical movement, sensation, vision, swallowing, or any change in their mood that does not limit their activities, they still should score 1. Patients scoring 1 can continue to take part in all of their previous work, as well as social and leisure activities. If there is any activity that a patient used to undertake that they can no longer do since the stroke because of a physical limitation or because they have chosen to give up the activity as a result of the stroke, then they should be scored 2 on the Rankin. In this category, the patient has slight disability and is unable to carry out all of their previous activities, but they are still able to look after all of their own affairs without any external assistance. They can be left at home without assistance for a week or so. If they can't drive only due to legal reasons, then they are not a 2. For example, a patient would be scored in this category if he used to play golf and is no longer able to do so, or if he used to have a job, whereas he no longer works. The patient should still be able to look after himself without any daily help. In other words, he will be able to dress, move around, eat, go to the toilet, prepare simple meals, undertake shopping, and make short journeys by himself. Ranking Category 3 is for patients who have moderate disability. These patients require some external help for daily activities, but they are able to walk without assistance. They may use a stick or a frame for walking, but the assistance of another person is not required for this. They will be able to manage daily activities, such as dressing, toileting, feeding, etc., but they will need help for more complex tasks, such as shopping, cooking, or cleaning. They may be visited more than weekly for assistance. This may be with financial help. Patients with moderately severe disability who are unable to walk without assistance or attend to their own bodily needs by themselves are given a score of 4. These patients are not independently mobile, and they will need help with daily tasks such as dressing, toileting, and eating. They will need to be visited at least daily, and they can be left alone for a few hours. We recommend that all staff undertaking MRS for patients complete the training below, which awards a certificate at the end. The link is also available on the website. Barthel Index. Please find the link to the copy of this outcome measure on the website. The Barthel Index, or BI, was first developed by Mahoney and Barthel in 1965 and later modified by Collin, Wade, Davies, and Home in 1988. The original 10-item form of the Barthel Index consists of 10 common ADL activities, including feeding, bathing, grooming, dressing, bowel control, bladder control, toileting, chair transfers, ambulation, and stair climbing. Items are rated in terms of whether individuals can perform activities independently, with some assistance, or are dependent. SNAP advised the use of the modified Barthel Index with scoring out of 20. Please review the slide for details of scoring. This is another version of the Barthel Index where scoring is out of 100. Please read the guidance for scoring. It gives explanations for each activity. The BI is easy to administer and does not need formal training of certificate programs. It is shown to be reliable and concurrently valid when compared to the motor part of the Functional Independence Measure and the MRS. It demonstrates excellent properties in organized inpatient trials. A number of studies have shown that the severity of disability, according to the BI recorded at 5 days post-stroke, show a highly prognostic accuracy for death or dependency as a final outcome. There are examples of BI assessment in studies of spinal injury, burns, cardiac disease, rheumatoid arthritis, amputations, and frail elderly. The BI is insensitive to small changes in functional status, which is due to the steps on the scale being fairly large. There is a ceiling effect. This occurs when a maximum score is achieved. However, a patient still has daily living restrictions. Therefore, the BI cannot discriminate levels of disability among the high-functioning patients. The BI allows for the use of compensation strategies when the non-paretic arm is used for grooming and eating. It does not reflect issues with communication or cognitive deficits. There are currently multiple versions of BI, which could hamper general use and valid comparisons. The next outcome measure we look at is the Nottingham Extended Activities of Daily Living Scale. The PDF copy is available in links on the website. This is a ranked assessment of patients' ability to complete activities of daily living, ADL, independently. It was developed for use with stroke patients. The Nottingham Extended ADL Scale is composed of 22 questions, split into 4 subsections: mobility, kitchen, domestic, and leisure. For each task, there are 4 possible answers. Not at all is 0, with help is 1, on your own with difficulty is 2, and on your own is 3. The next 2 slides show all 22 questions. The scale can be used as a postal or telephone questionnaire. The questions are about everyday activities. Whenever possible, answers to the questions should be given by the person who was the subject of the questionnaire. Answers should be recorded by ticking 1 box for each question. Answers should reflect what has actually been done in the last few weeks. The questionnaire should be a record of activity rather than capability. The interpretation of the scoring is detailed on this slide. Although this is an alternative version, it is not currently used by SNAP. The last outcome measure we look at is the EQ5D-5L. The link to the PDF copy can be found on the website. EQ5D is a standardized measure of health status developed by the Euroqual Group in order to provide a simple, generic measure of health for clinical and economic appraisal. EQ5D is designed for self-completion by respondents and is ideally suited for use in postal surveys, in clinics, and face-to-face interviews. EQ5D-5L comprises of 5 dimensions: mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. And each dimension has 5 levels of perceived problems. It should be noted that the numerals 1 to 5 have no arithmetic properties and should not be used as a cardinal score. The index value reflects how good or bad the health state is, according to the preferences of the general population of a country or region. The collection of index values for all possible EQ5D states is called value set. Currently, the National Institute for Clinical Excellence is awaiting expert advice on the EQ5D-5L value set for England. EQ5D-5L data entry on SNAP appears like this. Thank you to all those who have contributed towards this training over the years.